Let's talk about one of my favorite restorations, gold inlays. In my opinion, there's nothing that dentistry has come up with that's more stable, stronger, and precise than a gold inlay or onlay or a gold crown. Many times I'll do full gold crowns on second molar teeth, where the big muscles are, right on top of them, because you don't ever have to worry about them breaking. Any tooth-colored restoration, including zirconium crowns, can fracture. I've had them fracture. The dentists that are members of my teaching faculty when I had my teaching center in Dallas have had zirconium crowns fracture. Emax crowns, lithium disilicate, were supposed to be non-fracturable. They fracture. I've had them fracture. These dentists have had them fracture. So the only crown you can't fracture is a gold crown or a gold inlay. So in this case, I'm placing a gold inlay to replace an old composite restoration. See, here's the composite. Now, I don't do class 2 composites. Why not? It's very difficult for me to get a completely sealed gingival margin, and it's very difficult to get a really good contact. Plus, the coefficient of thermal expansion when you have a large volume of composite is not good. The coefficient of thermal expansion of composite is about 75. The coefficient of thermal expansion of a tooth is about 11. That's how much something expands and contracts when exposed to hot and cold. And the larger the volume of composite, the more the coefficient of thermal expansion comes into play. So if it's a big class 2 composite, the chances of leakage are tremendous, with the composite pulling away from the tooth, not having a good marginal seal in the gingival area. So for many reasons, when I see somebody with a class 2 composites on their teeth, I pretty much know if they've been there over 3 to 5 years, they're going to have leakage, and they're going to have a much bigger problem than they had originally if the tooth had been crowned or a gold inlay placed. Now, even processed composite or some type of laboratory processed tooth-colored material is better than just plain composite, because the coefficient of thermal expansion the differential is not as great. That processed tooth-colored material doesn't expand and contract as much as just a plain old class 2 large composite. So in my opinion, that's just my opinion, the best is gold if the patient doesn't mind having a little gold in their mouth. You can see this. So I'm giving intraligamental after giving a mandibular block, and I'm placing the rubber dam. And I use this rubber dam technique for almost anything. So learn how to use that rubber dam. It's going to save you a lot of stress. So this is the 33 carbide burr, and I begin the preparation. Then I'm using this mosquito diamond to perfect the interproximal surfaces of the prep, to flare them just a little bit. I want something with a straight side, as I want the inlay to be able to draw. Then I'm coming back with a fine, small barrel diamond. You want this mesial part to be widened just a little bit so it locks it in. See, this is widened just a bit. So all of these walls must draw, because that inlay is going to seep into the preparation. It doesn't need to be subgingival. This is reversible hydrocolloid, which is a deadly accurate impression material. And I always take 2 impressions, just because I never want to have to make that call to a patient if there was something on the impression that I didn't see and I need another one. This way you've always got a backup. For 40 years I've always taken 2. Now, reversible hydrocolloid is very inexpensive. It costs about $1 an impression. So sometimes if I do 2 or more crowns, I'll take a polyether with custom tray and a reversible hydrocolloid impression. If I'm doing a single restoration, I take 2 reversible hydrocolloids, but I always have that backup. And the second impression may just be used as a solid model to perfect the interproximal contacts. Watch the video in the library of dentistrymasterclasses.com on how to never have to adjust another interproximal contact using the solid model to perfect those interproximal contacts. Now this is just a quadrant impression. So the first one was a full arch, and this one's a quadrant. You want to wet the tooth with warm water before you place the reversible hydrocolloid impression, because the cold makes the reversible hydrocolloid set up. You see these hoses running through channels in the tray, and that's water. It doesn't have to be ice cold water, just room temperature water running through those channels in the tray makes the reversible hydrocolloid set up. If you put it in warm water or hot water, it makes it liquefy. So when you want to set, you run cool water. See how just deadly accurate. It doesn't stretch, it just pops out. Here's my prep, and I'm going to place IRM as a provisional restoration. You can watch the video on how to mix the IRM. You want it to be pretty stiff. You don't want it to be gooey. This is just perfect for a provisional restoration for an inlay. You want solid contact with the tooth behind. The patient's not going to floss this area while the provisional is in place, and they're going to eat on the other side. They don't want to break it out. We've just barely opened the contacts on the facial and the lingual. Remember, extension per prevention. You want to just barely open those contacts so that food debris or anything else doesn't collect right at the facial and the lingual contact. So if the patient were to lose this provisional restoration, mesial drift might cause the tooth posterior to it to drift just a little bit. So you want that provisional restoration to be in tight contact with the adjacent tooth. So now I've anesthetized the teeth. The patient's returning for seating of the inlay, and after I've anesthetized, I'm just removing this provisional restoration with my 330 carbide burr. Just light touch, not touching the tooth, and then using a scaler to remove any little bits, and then we'll floss that. Then isolate the tooth and clean it with isopropyl alcohol on a small cotton ball. Rinse it off. There's my inlay. Now, I have patients in my practice that have had inlays and onlays and gold crowns on their teeth for 75 years. I mean, it's like I say, it's like a shot put or a flint rock. They're just pretty much indestructible, and the margins are just perfect. So if these are cemented with resin cement, unless they're in an accident, they should have them for the rest of their life. Now, you don't want to place an inlay if there's not good solid tooth structure all the way around it. I don't ever place an MOD inlay. In that case, it would be an onlay or a full crown, because you don't want the patient to bite and split the tooth. So this is when there's lots good tooth structure all the way around the inlay, including the other mesial or distal area. I don't ever place MOD inlays. See, there's lots of tooth structure around it, so I'm not worried about a tooth fracture. Then I'm cleaning it with isopropyl alcohol, using this carrier with red rope wax on the end of a cotton tip applicator, and you can use that to carry veneers, crowns, inlays, just very handy. And place a little Vaseline on the interproximal contact, make it easier to remove any cement that were to get into that interproximal area. Then you wipe the tooth again with Tublicid Red, which is a desensitizer and disinfectant. This cleans it really well. And this is Unisym. And what about the tooth before you cement any restoration? I don't want it to be desiccated. I just want it to be fairly dry. I may even take a cotton ball, small cotton ball with hemostats, and just dab it. I want to have a hybrid layer, if possible, into the dentinal tubule. So having a little dampness is not a bad thing. The carrier is drawn into the dampness of the dentinal tubules to create that hybrid layer. I don't want to desiccate the tooth. Just a little bit of unfilled resin, cement, and this is Unisym. Then I put it to place and push it to place with that amalgam carver, the small amalgam carver. Then in this case, I'm going to wipe the excess with a cotton ball. And keep pushing, be sure it's completely set, then use some waxed floss. Now notice I didn't pull it straight up. Either pull it to the side or pop it to the side. Don't pop it straight up yet until the cement's completely set. Then wipe it. Have the patient bite firmly. Check the occlusion. Then I'm going to polish the margins with this football diamond, or you can use a fine chamfer diamond. And then I'm going to come back with Shofu rubber wheel and polish from the restoration to the tooth. And then I'm going to finish with pumice in water. That's the Dental Minute. These techniques work, and they work every time.
Take your practice to the top tier. Subscribe to dentistrymasterclasses.com for an organized library of all the Dental Minute videos, plus many complete comprehensive cases and many very important articles. New cases are added weekly, only $20 per month. Subscribe now.